And I'll start putting it on record so we have it. It's just amazing to think that we are covering now in an exam for next week, chapters coming from week 7 all the way to week 9. And in those 3 weeks, we did cover some intense things, cerebral and endocrine and neuromuscular. There's some heavy stuff. So I'm going to try to make sense of it for you. I'm going to try to put it in terms that you can figure it out. Because
can I ask you a question?
Yes, you can, ma'am.
So for the final exam, it's only chapter 7, 8. I mean, not chapter, but the week 7, 8, 9. It's not the whole content, right?
Okay, this is exam 3. It's only on content from week 7, 8, and 9.
Because in my other class, it's like the whole thing. And I was like, oh, that's a lot.
You're talking Med Search 2?
No. I'm in the leadership.
Oh, in leadership.
Mm-hmm.
Okay. Who is your professor in leadership?
Professor Strab.
Oh, he's so good. I
He's
love
awesome.
him.
He is absolutely amazing.
I love him. As somebody that I work with, as a, one of my equals. Oh, he's amazing. And, I love his humor. I like the way he talks. He's like a kid,
I don't know, but he's amazing. He keeps us up. Like we never fall asleep with him. He's just amazing.
I'm glad. I'll let him know that. He'll be glad to hear that. So it's chapters 41, 45, 46, 47, 48, 49. Oh, there's my little guy. How is he today? What a gorgeous dog.
She's good.
Oh, she is. Oh, sorry. I saw a blue tag.
This is Bella. She's our baby.
Oh, Bella. That's the name of my car, Bella. All right, let's get going, guys. Thank you for coming. Just to let you know, I am in thunderstorms. I'm usually okay, but I'll warn you, if I have a thunderstorm, I will come back. I will try to come back, okay? And make sure that whatever I get in a recording that you will get if I can, all right? So let's go. Exam, it's unbelievable. Exam 3. Exam 3, wow. So here's our review. So endocrine system, the week 7 was a little shortened in our lecture because it was the exam week. So, I put it through with a KAHOOTS that could really understand all of those concepts that we really need to know. So again, I will be sending week 7, 8, 9 KAHOOTS along with my recording to all of your professors. If by any chance you don't get them, anybody can send me a message, bbogart@fortiscollege.edu, and I'll make sure you get it, okay? Because I want you all to have the information that you need so that you can do well and be successful, okay? So you think endocrine, I think diabetes. That's my number one I think of. So children are usually 99% of the time, unless they're usually the adolescent, are type 1 diabetes. Now, one of the misnomers is I've had students think that as you get older, you could grow out of diabetes. Just to let you know, you can't. All right, once you're type 1, you are type 1. It just means your cells have been destroyed and they're not going to come back. So what do we see in children? And it is a classic. What you'll see is that drinking too much. You're going to see them urinating too much, and you will see drastic weight loss pretty quick. I remember a little 2-year-old girl who came in, she was tiny, had lost 5 pounds, and she had all these symptoms. And she did have a blood sugar of over 500. And that was when she was seen. So drinking, urinating, weight loss are the big things. And you might see them having enuresis or, wetting their beds at night when they usually don't. So decreased urine, increased thirst, increased hungry, and of course, all that weight loss. Now, there is a difference between hyperglycemia and diabetic ketoacidosis. So, they are both diabetes, but when you're talking hyperglycemia, it's just the elevated blood sugars. You're not going to see all the other symptoms. In diabetic ketoacidosis, Yes, you have hyperglycemia, but your body says, you know, I'm hungry. I need something, and goes for other food stores and goes to proteins and to fats. And with protein digestion, you see ketones. So elevated blood sugar, presence of protein in your urine, this is your definite signs of diabetic ketoacidosis. These children, when they come in into the emergency room, which, you know, those who know me know I worked in a level 4 trauma center emergency room for 10 years. These children would come in looking very pale. They would be drowsy, and you can smell their breath. It smells like a rotten peach. You know, put a peach in a Tupperware container, let it sit there for 2 weeks, open it up, and that sweet smell is exactly what it smells like. Now, you're also, you know, dehydrated with this. So decreased skin turgor, and you will also have not enough fluid. You're going to see the hypotension, but with this one, you see bradycardia. So here's all of these little signs and things. How do we treat diabetic ketoacidosis? Well, number one, we need to start an IV and give fluids. Fluids, 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 fluids. And then we will put them on a regular insulin drip, slow, continuous. And we know there's going to be some problems with your electrolytes, so replacing them as they need. So hypoglycemia, again, what are signs and symptoms? What would a child look like with just the blood sugar is too low? Now, children sometimes forget to eat or, you know, take their insulin, run out the door and forgot their, you know, what they were going to eat. And these children can become hypoglycemic. These children will become nauseous, they'll vomit, they're going to be jittery and sweaty, and you can look at them and see that they just don't feel well. So hypoglycemia, and the number of blood sugar is, they say, less than 60, but you have some children who can tolerate 40 and still be okay. I've seen it before, and it might even be lower. But when it's true and real hypoglycemia and they're showing signs, you know, these are what you'll see, and we need to give them some orange juice is a great thing. They also say, you know, some milk, all just to get that blood sugar up. And then of course they need something more substantial, you know, some carbs and some protein. Protein is important. Hypoglycemia, here we are, an acronym to look at: headache, irritability, tachycardia, another irritability, restless, excessive hunger, and dizziness. So these are your signs. We put a lot of new pictures because I feel pictures can show you something easier than just reading words. So, okay, another problem, endocrine system, pituitary gland. So we have an anterior and we have a posterior lobe of pituitary gland. The anterior has to do with growth. You know, how much growth hormone is secreted depends on how tall or short you'll be. Then we have the posterior, and it also has to do with oxytocin, vasopressin, and it's a lot of fluid stuff that will go on with that one, and we will go. So hyperpituitarism is when you have too much growth hormone, and usually it's due to a tumor. So these children, if we don't find out the cause for the extra growth, they can grow to be 8 feet tall, and they have distinctive facial markings, a big, thick face and the ears and long hands, etc. So we try to stop them before they get too tall because there's other problems, you know, medical problems that can occur. Now, hypopituitarism, probably the one I've seen more often, are your tiny children. You know, you have normal sized parents, these children aren't growing. So what they do is they can give growth hormones, and they will give them up to when they stop growing less than an inch a year. So if they're growing an inch a year, they'll continue it, but after that they'll stop, usually about that pre-pube growth spurt that goes on. These are injections that these children do. Many of them, they're sub-Q injections that are given, and some of these children even learn how to do it themselves. So let me see, hypopituitarism, they don't grow. And there's all sorts of reasons. It could be tumors, etc. And just because a child's short, and this is a good thing to mention, just because they're short doesn't mean they don't have enough growth hormone. So that has to be evaluated before we give it. Hyperpituitarism, precocious puberty. Now, precocious puberty is when hormones for puberty are secreted and it's earlier than normal, which means a 6-year-old girl could have boobs and breasts, okay? 6-year-old boys can have facial hair. That's part of puberty, going through puberty. So that's precocious puberty. And we can, again, stop it. There are medicines that can be given for that, but we don't mention it in the exam, so I won't tell you what it is. It's actually Lupron. All right, diabetes insipidus. Now we're talking about fluids and how the pituitary gland oversecretes or undersecretes certain sort of hormones that have to do with growth. Now, diabetes insipidus, there's 2 P's here: drinking too much and urinating too much. And as much as you drink, you're never satisfied. You're thirsty. Because of the amount of fluid loss, you have to be very careful with electrolytes. So diabetes insipidus, what are we going to watch? Priority. Well, vital signs. What do vital signs tell you? Elevated heart rate, right? I'm dehydrated, lower blood pressure, and those can be dangerous. So those need to be monitored quickly. So those are 2 priorities that we can tell without even knowing there's a problem. We can do some correction so we don't have a big issue. Now, syndrome of inappropriate antidiuretic hormone. Well, I look at that. Inappropriate means probably too much of against urinating hormone. So if you're not or against, diuresing or against urinating, what's happening to that urine? You're holding it. So now you are gaining too much fluid, okay? You're getting into swelling, edemas, you can have your lungs start filling up. So what is our goal with too much fluids going in and you're holding on? Well, you could be, having just fluids and congestive heart failure. What's the nursing treatment? We're going to be monitoring strict intake and output. You want to see that the output now could be more than the input to get rid of fluids, right? And then the other thing is daily weights. Daily weights, especially in children, and some of these can be small babies. It's the best way that we can monitor fluid balance. So daily weight, intake, output. And here's some great pictures, again, which are showing you those things and giving you a visual on exactly what I just said. So diabetes insipidus, you don't have enough ADH and the kidneys just pour urine out. So that's diabetes insipidus. And SIADH is when, you have, again, too much hormone and now you're holding on to the urine in you. So one is too much fluid and the other one is you're holding on and then you're losing, either or. They're opposite of each other. Again, diabetes, urine out, insipidus. And the other thing I want to make a comment of, so maybe you'll be that nurse who doesn't work in an emergency room and bring me a patient that says, your child has a history of diabetes insipidus and their blood sugar was 98. I want you to know blood sugars have absolutely nothing to do with diabetes insipidus. It is all about the hormones with urine outputs and holding it, okay? So diabetes insipidus, you're losing fluid, you get dehydrated. That's what we look for. Intake, output, daily weights on both these patients. The syndrome of inappropriate antidiuretic hormone, you're holding on to urine. So we're going to limit the salt, limit fluid intake, watch INOs, and do daily weights. So I think adding those pictures really help with remembering. So thyroid. Thyroid hormone is either too much, too little, and hyperthyroidism is also called Graves' disease. usually occurs right around that pre-adolescent, 12, 14 years old. And hyperthyroidism is treated in several ways. We could either, remove the thyroid, we can ablate it, radioactive iodines, or we're going to have the thyroid in, but we're going to give medicine. Now, one of the things that we need to teach our patients that have Graves' disease that are on this medicine called polythyroxyl. I mean, I know it is PTU also. Sometimes it's prescribed that way. This medicine can cause leukopenia, which means what? These patients do not have that big defense against infections. So these patients could have fevers and sore throats. And when they do have that, even though maybe it's a common viral illness, we should be telling our physician because it could be something to do with the medicine, okay? So how do we treat the leukopenia with this? So we're showing that we're having fevers. We decided it's about the PTU. We're going to give glucocorticoids, and that's what helps with that. Now, one of the things that can happen with hyperthyroidism is what we call a thyroid storm. It's like all of a sudden, poof, all of this thyroid hormone is thrown into the body, and it does not feel good at all. I was at work, and one of my younger workers with me had hyperthyroidism and went into a storm. She went red. Her fever went up to 103. Her heart rate went up to 160. She had tightness in the chest and difficulty breathing. And what do? Well, we have to slow the heart rate down. We're going to be giving the propranolol. That, thank goodness she was working with me that night. So hypothyroidism is not enough. And this is the most common of the thyroid illnesses, and it's most common of endocrine problems in children. Now, if we know what hypothyroidism is with adults, it's the same thing with children's. The only difference is you're going to see a child not growing as tall as they should without thyroid hormones. At birth, children who are not moving their bowels within the first 24 to 36 hours, they're going to check for thyroid because it's one of the signs and symptoms we can catch at birth. But what do we see? So we'll have the decelerated growth, dry skin, puffy, that sparse hair. Children usually have nice, big, full hair. Well, it's going to be really sparse. Also, as I said, constipation, not just at birth, but, throughout, as you, whatever age you are. Sleepy, and then mental decline. And these are things we will see. So hyperthyroidism. I think when I think of hyperthyroidism, I think of up and excited and jittery. And I think of rapid heart rate, weight loss, and I know those big bulging exophthalmos eyeballs. I think of the commercial on TV where she's wearing sunglasses and she's on these new drops. Hypothyroidism, you're going to see them down, heart rate down, weight gain, because everything's slower, constipation not working as good, diarrhea too fast on the other side. So I think this is a great picture which shows you the both, and you can compare, they're opposite from each other. Cushing syndrome is an adrenal problem. It's uncommon in children. We mention it because it can happen. It is caused by an overproduction of the adrenal hormone cortisol. And what do you see with Cushing syndrome? Well, it causes an increased sugar, which causes fat. And your cheeks get big and puffy and big, they call them ruddy, which is like pink, like darkened cheeks and the chin. And you're going to see, a bigger abdomen, but their extremities are going to be like thin extremities. They're going to be, almost emaciated looking because of muscle wasting. And the weight gain, and they can have hair. I actually went through Cushing's, and the one thing was I saw extra hairs on my chin. So I was on steroids and had to be weaned off. That's why we go slowly, right? Neurologic dysfunction. So when we're doing a neurological examination, we're doing it because when they're first admitted, because we want a baseline. We want to know what is normal for that child, because the best thing about children is they're all different. So we want that baseline for that child. So some of the things that we can do that can affect cerebral function is anything to do with the head, which is you take lumbar puncture. What are you doing? Taking cerebral spinal fluid, which comes from the head too, right? Head injuries, bacterial meningitis, edema, a hydrocephalus, seizures, anything in the head can touch it. So what is a seizure? Well, I call it, there's an electrical thing in the head that goes bzz, and it causes the body to react in many different ways, okay? Very simply, I think that makes me understand it. That electrical activity puts like a zap. And what happens? Well, it depends on where this occurred, what region, because every region in the brain does different things. Some has to do with movement, sometimes behavior, sensation, postures, they all are different. Now, seizures are a symptom of something else that's going on. So we can treat seizures, but we need to find a cause. Now, epilepsy is when you're seeing 2 or more unprovoked seizures less than 24 hours apart. We know that unprovoked means it's not like a febrile seizure, right? So that could cause it. And febrile seizures, you'll have parents ask, does this mean my child has epilepsy? No, it doesn't, because epilepsy is 2 or more unprovoked seizures in 24 hours. And we know seizures because of fevers due to the fever caused them. Causes of fever, what can happen? Well, we have infections, we can have lesions, hemorrhages, metabolic, trauma, malformations, genetic, toxic, and then of course the last one is a fever. So in cases with child having a seizure, what do I need to do? Well, you can't prevent a seizure. I mean, we can put them on medications and hope to control them, but children will still have a seizure. What is our number one priority? And that is keeping this child safe. That means if they're in bed, put it flat, get rid of pillows, pad the side rails, turn them on their side. Do not, of course, put anything in their mouth, and basically make sure that airway is open so that they can breathe. So again, teaching parents what to do for a seizure, turning them on their side and, keeping their airway open. So there's all sorts of seizures. I knew them as grand mal, and, now they're generalized or tonic-clonic seizures. I think probably when we think of seizures, we don't think of that little tiny little eye moving or blank stares. We think of tonic-clonic, which is the arms and the legs, flexion, extension, and posturing. Usually there's a loss of consciousness, foaming at the mouth. That's what I think of usually when I think of the seizure. So again, how do we take care of them? We protect them, we keep them safe, we keep their environment safe so they don't hurt themselves. Now, cerebral palsy is a permanent disorder of the development of posture and movement causing activity, limitation, attributive non-progressive disturbances that occurred when the fetus was developing in the infant brain. So there are different types of cerebral palsy. There are children very mild, and there's non-spastic, and then there's spastic. Now, cerebral palsy, the spastic ones are those children who really can't control their muscles at all. They have difficulty maintaining balance, and it's that hypertonicity. I told my class about my little Jonathan, who I love dearly. He was this little boy, 6 or 7 years old, and he would see me, his smile would go ear to ear, and his hands would come up and he would just start spasming just like that, because he knew I was going to go give him a hug, and give him a kiss. So that's that hypertonicity. So here we are, the different types of cerebral palsy. Think of spastic, that's probably the most common you'll see. Head injuries. You know, head injuries in children is anything to do with the head, the skull, meninges, it's all part of that. And how do these things happen to children? Well, injuries, children, always motor vehicle is, you know, one of the top of the list. But falls, these kids tend to climb on top of couches and dive bomb to go to the other couch, miss, hit the floor in the head, and those things. Bicycles and sports injuries in children, you know, that are into the little league and soccer and all those, you're going to see those head injuries going on. Now, one of the things about taking care of a child with a head injury is to make sure that what are we doing? We need to do a good neurological exam. We need to know their level of consciousness, because they will have periods of what we call amnesia, or like asking that same question more than once. Slid into third base and hit somebody's, you know, head, and, you know, was brought in because he went unconscious. Now, kept asking, so was I safe? Was I safe? Is daddy coming? Is daddy coming? And you've answered these questions a lot of times. That's what I consider as amnesia. Of course, pupils, because we worry about swelling in the brain, very important. Now, if you see a child who is vomiting and it's increasing, getting more and more than 3 times, and their pupils are starting to change, they're getting bigger or they're fixed, they're not moving, you know, these are what we consider a neurological emergency. If you have a child that has one eye that's completely dilated and fixed, again, neurological emergency for that child, okay? So, child with a head injury, change in level of consciousness, or they're acting worse, or now they're not waking up, now they're not responding at all, that's a problem. Vomiting more than 3 times, that pupillary changes, they're, you know, not responding as quick as they should, double or blurred vision, and then trouble walking, you know, child's walking and all of a sudden they started shuffling and almost falling over, that's a problem. Complaining of a headache that becomes more and more, that means pressure's building up in that brain. If it wakes him from his sleep, we know there's a problem going on. And that, as I said, a fixed dilated pupil is a neurologic emergency. So spinal cord injuries, your priority above all is to keep that spine immobilized. I was telling my class yesterday, I had a 16-year-old boy slid into third base and his head hit the knee and it cracked the spine. And he had an angulated C5, C6 fracture in his spinal column, and he had paralysis in the right side and almost complete in the left. I got that kid through an MRI, got him, you know, up to ICU, and the outcome, because I monitored that neck, that spine so closely, the kid's walking and is perfectly normal today. And that is a nurse. Nobody else, that is a nurse, you making sure priority, immobilize the spine and be very careful with turning, positioning, and moving. Now, meningitis is a bacterial or viral infection that goes into the meninges and into the brain, okay? What do we see? Well, fever, chills, headaches, stiff neck, sensitivity to light, all of those things. Okay, we're going to see that Koenig sign where the head comes, the Brzezinski, and the head comes up and the knees can't, you know, extend. All of these things are going to show you. Now, how do we treat meningitis? Well, it doesn't matter if it's viral or if it's bacterial. We need to find out. I mean, of course, bacterial is going to get antibiotics, but a viral, you know, we need to know so that we know how to treat them. So bacterial meningitis, we are going to do a cerebral spinal fluid, and we are going to do, you know, do that lumbar puncture, and we're going to check what's going on. Now, a low glucose, bacteria loves glucose, so it eats it up. So low glucose, elevated white count, and increased protein, and it's going to, this fluid should be clear. It almost sometimes looks like milk. Sometimes it's cloudy, but sometimes in severe bacterial meningitis, it looks like milk. This is what you will see when you do the spinal tap and what things that you're going to look for. So how do we take care of a child after a lumbar puncture? Well, we know that you've taken some fluid off of the head, and the fluid is around there. So this child needs time for the body to get accustomed to that amount of fluid being withdrawn. So have them lie flat for at least 30 minutes. It's almost like spinal anesthesia, same thing. Keep them flat, give them fluids, and then slowly get them up. So meningitis, it's IV fluids, antibiotics. And because their heads are tender and lights, etc., keep them in a quiet place. Remember, it can cause swelling, so you have to worry about cerebral edema. Now, it does, in cerebral edema, there's several ways you can get extra fluid in the head. Could be from a fall, could be, blood that goes in there, or fluid because of the meningitis. Now, how do we treat it? We got to get rid of that. Pressure's building. This child is now severe headache and probably getting extremely confused or even unconscious. How do we get rid of that fluid quickly? Well, we have diuretics, but the one that should be used is mannitol. This is the antibiotic to use to decrease cerebral edema extremely quick. Now, because we're giving that, because we know that they're having this cerebral edema due to the assessment and what they're showing us, we need to carefully monitor fluid intake and output. And children with meningitis are extremely contagious to everybody. So strict isolation for 1 day. They say after 1 day of antibiotics, then you're, safer to be around that child, okay? Again, monitoring change in level of consciousness, lethargy, headaches, projectile vomiting is what you're looking for with increased intracranial pressure, fluids building up. And then infants are great because they've got that fontanelle sitting right there. And if they're just sitting there, not crying, and there's a bulge, it's rounded, and it feels like a tight trampoline, that's the one that has increased intracranial pressure. Now, myelomeningocele is one of the most common causes for problems with bladder dysfunction in children. Why does that mean? Well, what happens at birth, the back of the spine, the tissue doesn't close, okay? And the meninges and spinal cord are pushed up and out of that. So as I'm saying, if that spinal cord and meninges is pushed up and outside the body, those nerves have stretched. And those nerves that have stretched could break. So lower extremities, you might have decreased function. Excuse me. Sorry. My mother-in-law trying to call me. I hung up on her. Okay, so you've got this meninges, spinal cord on the outside. Those nerves have been stretched and some are broken. Those nerves supply the bladder. They supply the lower extremities, sensation and movement. So one of the things that we really need to monitor on these children is urinary function and constipation. It's all to do with nerves down there. 1 second. Let me call you back. I'm in the middle of teaching. Thank you. No, he didn't. I'll tell him. Poor lady, I almost had to hang up on her. Okay, Reye syndrome. Reye syndrome is when children get aspirin and they shouldn't be just given aspirin for anything. The only time we give aspirin to children is to treat Kawasaki. And we give them aspirin because it thins the blood and it prevents clots. And that's Reye syndrome. So hydrocephalus. Myelomeningocele actually sometimes have a problem with that cerebral spinal fluid, and now it can cause extra fluid to be up in the ventricles of the brain and a lot of swelling going on. So How do we treat this? Well, we put in what we call a ventricular peritoneal shunt, and it goes inside the ventricle in the brain, comes out behind the ear, comes in front of the neck, down into the peritoneum, and it just drains the fluid, okay? Now, do not ever, there's a little pump, never pump it, okay? That's a big do not do. Nursing priority is to measure the head circumference and abdominal circumference because it is draining there. Postoperatively, we need to know, where does the doctor want this child positioned? Does he want it on that side or on the other side, right? So that's how we work with ventricular peritoneal shunts, and we use it for what? Hydrocephalus, too much fluid in the brain. Comatose children, number one priority is always, any child who's not awake and alert, you monitor airway, airway, airway. And you know, you have children that are nonverbal, you have children comatose, and you know, they do have pain. And how do you know? Well, usually comatose children will be on at least a minimum of a SAT monitor, O2 SAT monitor, and we can watch saturations drop a little bit, or we can see respiratory rate go up, heart rate go up. And sometimes you see the frowning, you know, in the head. And sometimes you might see a little groan, or you can tell this child somehow does express that they have pain. Now, near drowning, submersion, you know, I live in South Florida, so I've seen quite a few drownings, you know, in my life. And most of these children, you know, we get them out and get them up and we revive them. And by the time rescue comes, they're running around. Problem is, these near drownings will and can still have problems up to 72 hours after they drown. You know, we know that near drowning, the big thing is a period of time where they were hypoxic, you know, and this can cause the lungs, you know, to go into spasms later on. Your priority in near drowning, I've talked, is fluid in the lungs, it's hypoxemia. We're going to be monitoring respiratory status. Now, the GI system, mouth to anus, that's the whole GI system, okay? And its goal is to, for digestion, and, you know, to get the nutrition into us. There are several disorders that can cause problems with fluid electrolyte balances. We know that GI does and can lose large amounts of fluids, you know, and it can lose a lot of electrolytes. Vomiting can lose the fluids, electrolytes, diarrhea, fluid electrolytes, you know, so the GI system plays a lot to do with fluid balance. In children, one of the most serious life-threatening problems, and we don't think about it, is dehydration. You know, children need to keep hydrated. Dehydration is extremely serious. So when we see a child, elevated heart rate, you know, decreased blood pressure, you know, bad skin turgor, you know, dry lips, increased capillary refills, all of those things, you know, we really have to act on it pretty quick. But how do we give it to the children? Well, if a child is vomiting, you can't give them anything by mouth. So what would we do? If they're vomiting, we're going to start an IV for fluids, okay? If they are diarrhea, we can give by mouth a fluid electrolyte like Pedialyte, Gatorade, Powerade. Now, one of the things children do, they can vomit, okay? Whenever I get a child, they'll say that the baby's vomiting, especially the young ones between 3 weeks and 3 months. They come in and they're vomiting. So my first question, does it dribble or does it shoot out? You know, projectile. And if it's projectile, it's different than just dripping. So pyloric stenosis is classified as forceful projectile vomiting. It doesn't cause dehydration though. what happens is the pyloric sphincter gets thickened and muscular, and the milk or the breast milk just can't get through. It fills up the stomach, and all of a sudden it's too much, and it just comes out in a projectile vomit. Now, if this child, they're telling me it is coming out projectile, you put your hand around the mid, right underneath the xiphoid process and the mid abdomen, a little bit sometimes to the right, you're going to feel what feels like an olive. And what is that? That is that thick muscle of the pyloric sphincter. And this child will need to go to surgery. Now, what do we need to do for this child, getting them ready for surgery? Well, number one, they need to be NPO. They're just going to vomit some more. We don't want to do that to them. So NPO, start an IV, and sometimes they put them on antibiotics in case they felt they might have aspirated during one of these vomiting things. So they do surgery. It's called a pyloromyotomy, which means they just cut the muscle and open it up. And post-operatively, we'll start them on some clear liquids slowly. And once they tolerate it, then we can send them home. And usually there's no long-term problems with it. Now, Meckel diverticulum is this outpatching or bulge that's in the small intestines, close to the large intestines. And the only way we know that there's a Meckel's diverticulum is bright red, painless rectal bleeding. You might see a little bit of cramping around the belly button, but it's not as severe as you would think. So that painless rectal bleeding, we see it. What do? We go and we do surgery and remove that piece of diverticulum, and then they do well. Appendicitis is that place between the small bowel and the large bowel. There's this little piece of tissue called an appendix, which doesn't really do anything, but when it says, I don't want to be anymore, it creates a lot of pain. Now, children with appendicitis are just like adults with appendicitis. Right lower quadrant pain, McBurney's point, right? And you'll see, the rebound tenderness, all of that good stuff. Now, if they get to surgery and it's already ruptured, the outcome postoperatively is different than a child who, has an intact appendix. An intact appendix, they go in laparoscopic, they take it out, they go home the next morning, and that's fine. If it has ruptured, this child will be kept NPO. If you can imagine, the appendix has all of this, liquid in there that's full of irritants, and it just explodes into the peritoneum, and that bowel gets covered in it, and it gets angry. So we need to keep that bowel empty so that it can, with antibiotics, can, heal those, your bowels. Now, to keep that bowel empty and keep it happy, we have the child NPO, and we put an NG tube down because we want to keep the bowel empty, because our stomachs are always, producing, gastric juices, and we don't want that acid going into that, your bowel, because it hurts. It really hurts. So IV fluids, antibiotics, we will be an NG tube, usually on a low intermittent suction for it. And remember these wounds to be checking that surgical site, because the appendix burst, and it was a dirty area when they closed it up. So was the tissue good and healthy? So monitoring for this wound is very important. And of course, pain medicine. Get them up, get them out of bed, coughing, deep breathing, all of those things. Hirschsprung's disease, it's also called megacolon. It is the, distending colon where there's just no nerves in it, okay? There's no nerves in this area, which means what? Well, number one, there's no peristalsis, there's no movement, and it just stretches and it collects because it can't go down. And if you notice this picture, there's this tiny little tube that goes down and the end is the rectum, okay, the anus. Sometimes a little bit can squirt through. So sometimes you see a little bit of stool, ribbon stool. And this is at birth, we find this, okay? So again, another condition that there is no bowel in the first 24, no stool in the first 24 to 36 hours, we will be suspecting could be a possible Hirschsprung's. What do? Well, we find a ribbon stool, we feel the abdomen, we could feel something. We are going to be doing an x-ray, a rectal biopsy, find there's no nerves, and they will take that piece of intestines out. It's useless, there's no nerves, it doesn't work. So, and then they'll put the two ends together. When it's first done, the intestines cannot be put immediately back together. They will put a colostomy. Sometimes it's 3, 4, 6 months later, then they will close it back up. And most of the time it is. So these children will go right to surgery, have a colostomy, and then we'll need to come back for closure. Hepatitis, you and me, make sure we always wash our hands. And when we're talking about hepatitis, we need to make sure that they have a good diet. So it should be high in carbs, high in protein, and because the liver helps digest fat, and it's not working good, that liver, we're going to be low in fat, or you're going to have abdominal distension and a lot of abdominal cramping. So that's your diet for hepatitis. And of course, wash your hands. We know Hep B vaccines are given right at birth. So it's trying to help. Now, celiac disease is an autoimmune disease in which the body overreacts to gluten. Well, gluten is found in food, wheat, barley, and rye, which means your bread, cakes, pies, etc. You know, we're lucky today because they do have gluten-free products everywhere. I mean, years ago they didn't. So it's easier to take care of children with celiac disease today than ever. These children can have an omelet, a bacon omelet with cheese, and they could have orange juice, they could have milk, they can have vegetables. So there's so many things that they can have. So we don't focus on what they can't have. The one thing, of course, with gluten is to be careful that those chicken nuggets, they have bread on them. So, you know, to be careful. And macaroni and cheese is noodles, and that also is gluten. So you have to be careful. So these children have a problem with nutrition. One of the things they cannot absorb well is fat. Well, not only is it fat, it's also fat vitamins, fat soluble vitamins. So A, D, K, there's one more. Well, the fat soluble vitamins. So we need to give those replacements for them. So we have to be careful, you know, with nutrition on these children. Hepatitis, I've basically sort of mentioned it already. We know that it's just an inflammation of the liver, and we will see things because you're not getting the bile in, you know, the intestines for, you know, nutrition to be able to use it, that we're going to see, you know, these clay-colored stools. Clay-colored stools is there's no bile, so you don't see the color, and you're going to see that pain, et cetera, et cetera. Again, treatment, high protein, high carbohydrates, and be careful with fats because these children still need nutrition, so we need to give them what they can have. Now, GERD, reflux. This is when the stomach takes the food and shoves it back up into the esophagus, and it causes a lot of pain. What do we do for GERD? Well, if they're an infant, you know, we're going to be teaching parents how to teach them smaller quantities, burp them frequently, positioning afterwards, maybe place them on medications, your Zantac, Pepcid, you know, your proton pumps, all of that medicine, just like adults, we can give to children, but in their dose. Now, sometimes, no matter what we've done, and sometimes it ends up to be those older children. Older children, what do you see? They're refluxing. How would we know? Well, these children would be complaining of pain, in their chest, but they would have a horrible cough. And why a cough? They're aspirating and aspirating. So at that point, now your lungs are being, hurt. So we need to do something to protect them. And what we do is what we call a Nissen fundal plication. And all it means is we're doing a procedure that will not allow food to go back up the esophagus. These children should not vomit. Any Nissen procedure, you can know if they're vomiting, something is seriously wrong. And they just take the top of the stomach and twist it around and stitch it so that food can't go up. We use this a lot when we put in gastrostomy tubes. GU, these are all the things that we need to know about, and let's keep going here. So, gastroenteritis and dehydration. Well, children can have vomiting and diarrhea. They are always, as I call it, swapping spit and all their germs when they're playing in daycare, school, sharing things, and they're always, one kid gets vomiting diarrhea, you're sure many of them are going to get it. So what do you see? The thing with having gastroenteritis is that you're losing fluid. So fluid is being lost. Not only is it being lost by vomiting and diarrhea, it's being lost by that sweating due to fevers, okay? So fluid replacement is what we need to do. You're going to see the elevated heart rate, decreased blood pressure, decreased urine output, all of those things. So how do we treat this? Well, when they come in, they're dehydrated. We'll give them a bolus of normal saline. Never, ever give a bolus of sugar to a child, and never give fluids to a child that hasn't urinated with potassium in it, because potassium is only added to IV fluids after the child urinates. And if they're dehydrated, most likely they have not. And how do we really monitor dehydration? Is monitoring their basic metabolic profile or their electrolytes. What are their electrolytes? What are their sodium? What is their potassium? Children in dialysis. Well, we know children can have kidney damage due to many different reasons. It could be hereditary. It could be due to something structural. All of these things can happen. Now, if we have a child that needs dialysis, we can do, number one, we try to do peritoneal dialysis at home. Now, peritoneal dialysis is great. They put fluid into the belly, it sits there, and then it drains. The difference between what fluid you put in, what comes out, your urinary output. And what's the best part is done at night while the child sleeps. So during the day, the kid can be a kid, which is awesome. Now, how do we, what do we teach parents? I mean, they're taught all the procedure on how to do it, how to hook it up. It is a sterile procedure. Why is it sterile procedure? Well, your peritoneum is the kidney, and we do not want anything to affect the way it functions. And infection can really harm your peritoneum. So how would you know if the peritoneum got an infection? Even if you're so careful, it can happen. Well, you start seeing cloudy diastolate drainage. And the diastolate is the fluid we put in there. So usually that's an infection. What do you do when you see all of a sudden the fluid changing to a cloudy color, different color? Something's not right. Number one, call the doctor. And the doctor then will prescribe an antibiotic. I mean, you're not going to have just antibiotics to give. So call the doctor and he'll tell you what to put them on. Now, nephrotic syndrome, I'm going to say something 3 times. It has nothing to do with kidney failure. Nephrotic syndrome has nothing to do with kidney failure. It's not acute, it's not chronic, it's not kidney failure. It's the kidney saying, I don't like you proteins, goodbye, get out of here. You lose protein like crazy. So you're urinating, okay? And what you see is massive protein in your urine. Where does that protein come from? Well, it comes from the blood. So what's going to happen to the blood? It's going to be low in protein. So what happens? Fluid goes interstitially. So what do you see? You see all of this swelling, even the mouth, the lips, the gums, eyes, you'll see fluid everywhere. So again, too much fluid. What do you do for this child? We are going to be monitoring intake and output. We're going to be very careful with salt, and we're going to be watching that blood pressure really closely because of all of this extra fluid that's in there. And, you know, when we talk about albumin, you know, we're talking about that protein that's in the blood. So be careful of any medications we give these children. So again, nephrotic syndrome, you're pale. That's an acronym to remember. Proteinuria, hypoalbuminemia, which means low protein in the blood, hyperlipidemia, which means extra fat, and swelling. So again, intake, output, salt restrictions, daily weight, priority in nephrotic syndrome. So acute glomerulonephritis is all of a sudden you stop urinating and maybe you'll see some blood in the urine and you go to the doctor. And the doctor's going to ask you, has your child been sick lately? It is caused from a strep infection, like rheumatic fever, same thing. It affects the kidneys. And it's usually that stop urinating and you start seeing your child swell that brings them in. How do we treat acute glomerulonephritis? Well, what does it do from? It's due from an infection. We're going to treat the infection. So headaches up because the blood pressure's up. You know, you're going to be seeing that, again, proteinuria, hematuria, oliguria, correct it all. And this, most children are cured from this. Chronic kidney disease is when there's kidney damage for more than 3 months. What happens is kidneys are supposed to remove the waste and the toxins and fluids. You know, the vitamins and minerals are regulated there. And then, of course, all the hormones and vitamins, which has to do with red blood cells, okay? With chronic kidney disease, you know, it does monitor red blood cells, right, in the kidneys. So making sure that, you know, how can we increase that, you know, help that child, prevent them from getting multiple blood transfusions. We give them erythropoietin, and we give it to them because it forces the body to produce red blood cells. You know, in chronic kidney disease, of course, it's always rest. Now, sometimes we're trying to diagnose a child. Maybe it's chronic, you know, chronic kidney disease, pyelonephritis, you know, so we're going to go in there and do a biopsy. Now, it's important that we know what to teach the child and for what you to know about it. And what they do is they go directly in the back into the kidney and they will take a piece of it so it can be examined to see what's going on with that kidney. Now, these children, because it is, you know, a procedure, will be NPO before the procedure, and they will get something. Some of these children, depending on them, you know, might have more of an anesthesia. Some children might just have something, you know, to keep them calm. They will be, after the procedure, we need to know how to take care of them. Well, they have this hole that went through their back into their kidney. It's a possibility that that area could leak, whether it's into the peritoneum or out onto the bed. So nice big pressure bandage. And if the child's big enough and it's possible, put a sandbag there. It's like putting your finger on there and keeping it there. These children must be on bed rest for 24 hours. And of course, it has to do with the kidney. So we got to watch that intake and output. And as I said, it could leak inside the belly. We're going to watch for abdominal pain and tenderness. Now, kidney transplant is sometimes done because, you know, the kidney's not working, and children actually do very well with kidney transplants. Now, rejection is the most common cause of transplant failure. It is rejection. Yes, we put them on immunosuppressant therapy, prednisones, etc. But sometimes they do reject. And again, still, kidneys, erythropoietin. We want that red blood cell to be there. We want that child not to be anemic, because with anemia, you don't have energy, etc. So what do you see when you have a child who is rejecting? Well, you're going to see a fever. You're going to see some swelling and tenderness going on. And if it's not working, it's rejecting, you're going to have decreased urinary output, which means what? You're saving fluid, which blood pressure goes up, and you're not getting rid of the toxins that kidneys remove, like the creatinine. So that's going to be elevated. So what would be a nursing diagnosis? Risk for infection related to immunocompromised state and post-transplant medication. That's a great nursing diagnosis. Fractures, this week's lecture, common in children. We know that the treatments in children are different because children do heal quicker. We know infants 2 to 3 weeks. Younger children could be 4 weeks. So it's pretty quick that they get a cast on and off. Usually children, it's the arms. What do you do when you fall down? You put your hands out. So it could be one arm or two arm, one bone or two bones, doesn't matter, it happens. Usually it's because of out on the bike, riding around, fell off again, or sports injury. If it is an infant with a fracture, be aware, your job is to keep children safe. If an infant has a fracture, it's not common. So it needs to be investigated so that child is going to go home to a safe child. So there's types of fractures. Simple, normal. It's what usually you see in a fracture. Fell down, you see swelling in the wrist, it's a fracture, it's not open. Now, open or compound, those fractured bones, you can see it sticking out the skin. What is our concern? The bone is out into the air. We're worried about infection. So IV antibiotics for that one. Complicated is like rib fractures, where it damages organs or tissues. It could go into a lung, puncture a lung. Comminuted, it has fractured and split inside, and there's pieces of that bone, which causing all sorts of pain, and that's comminuted. And here's all the different ways, types of fractures. That spiral, that twist one, it's the worst one of all, but those are your different types. Now, cast care. Now you think of cast care, number one, think of those 6 Ps, right? We're going to be monitoring what that looks like. So post-cast, we need to keep that cast elevated so there's no swelling. Let's say it's an arm, keep it up so it doesn't swell, okay? Keeping your fingers, don't push them, because when they go home, it's still a little wet, okay? It should be air dried. You take a little cool hair dryer, and actually that the breeze actually really helps them also, because it actually feels hot. You need to be monitoring for movement, swelling, sensation, and these children need to be on limited activities until they get the okay from the physician. Okay, so they should have a couple days rest. So here we are, here's 5 of the Ps. There's 6, there's 5, they're all about the same. So pain, pulse, pallor, paresthesia, paralysis, because these casts with swelling could actually decrease blood flow and cause necrosis of tissue. So teaching parents this and knowing it too is important. Now there's different skin traction. There's skin, skeletal, cervical, and they're all done for different reasons. Most of the time when I discuss this, I'll talk about skin because you can have the picture. So you get a fractured femur, and that little bone is sticking, those 2 pieces of bone are sticking in tissues and nerves and causing muscle spasms and severe pain. That traction will pull it so that these bones come together, and it will decrease all of that pain. And it will give the physician time to be able to do surgery to correct it. So it's all about getting that bone straight, preventing deformities, and also to reduce those muscle spasms. So how do we take care of any, it doesn't matter, cervical, if they're in the one like the tongues, or if they're on skin, or skeletal traction, things we need to do to watch it? Well, we're going to watch the temperature of the extremity. If it's hot and red, it's swollen, it's going to have an infection. Biggest thing that we do as nurses is making sure that traction is functioning correctly. As I said, it's pulled that bone out. It's eliminating muscle spasms and pain. We want that rope to hang because it comes pulling, goes over a pulley, and these weights hang. Those weights must be free hanging. They do not need to be placed on a chair or anything, and it's 24 hours a day. Okay, and we will be checking circulation checks, neurovascular signs of this extremity. And they like to put these overhead trapeze on older children. They can move easier with less pain if they do it themselves. So traction nursing responsibilities. Again, make sure that the ropes are unobstructive and that the pulley is down, it's hanging freely, that everything's aligned well. And as a nurse, you're going to document the number of pounds of weight on there every 12 hours in your note. And now scoliosis, that's S-shaped type of deformity. And this is just a child whose spine is crooked. And how do we know? Well, if you look at the shoulders, it's easy to say this is a more severe one because it required surgery, but you'll see the shoulders start, one's up and one is down. Now, it is, twisting and all different movement of the spinal column. And the thing that we treat scoliosis with, any child who has a scoliosis less than 45%, we will treat it by wearing a brace. Now, we know that this is the pre-adolescent growth spurt time. So this is that young adolescent. They're going through body image, and they all feel they're not pretty enough, their hair's not long enough, they've got too many freckles, they're all into that. Now put a brace on their body from, underneath their arms down to their lower than their hips. And they need to keep that on 23 hours a day. They only take it off to bathe. So one of the nursing diagnoses is disturbed body image, and you can see why. These children, really are, having that brace on makes them feel different. So sometimes making braces in nice designs or colors or something also can help. Now, scoliosis with curves above 45% will require surgery, the Harrington rods. They put little rods next to the spine and try to straighten it up as much as they possible. Because that scoliosis, that curvature is squishing one of the lungs, so it's compromising your lungs and oxygenation. So again, these little braces, those are pretty cute that they can wear, and it will straighten them out. So braces and physical therapy, straightening up and strengthening those muscles can really be helped. So osteomyelitis. Osteomyelitis is an infection of the bone, and it's caused by, sometimes I didn't even know what happened, but it does. What do you see? Well, a lot of times I've seen it actually in the big toe. They've stepped on something, didn't know, kids run around, no shoes on. And what you'll see is the red toe is swollen, it's red. Sometimes they see streaks going up it, and it brings them into the physician. They have fevers, they don't feel well. And of course, you'll see lymphocytosis, elevated white counts. And these children need, as soon as we can, to be placed on antibiotics. Remember, these antibiotics are usually to treat staph, and staph is the aminoglycosides. This is the one that we have to monitor peaks and troughs. And we have to be concerned about their kidney status and their hearing. These children will be on bed rest. These children need good diet. So what diet would a child with osteomyelitis need? Well, they need good protein and calories in their diet, carbohydrates, the order for healing, because it does take time. And remember, this is going to be an immobilized child. So, you know, they need those help with psychosocial problems. Sometimes it needs surgery. Sometimes they have to drain it. Sometimes they find, you know, a piece of stick or something in there and they do remove it. Sometimes it gets to the point where, you know, it's gone too long and they can lose a limb. They could lose a toe. They try not to do that, but sometimes they have to. Systemic lupus erythematosus. The body just starts attacking its own organs. Okay. Now you're going to see different things. You'll see headaches, fatigue, fever, joint pain, and then that little rash that you see, butterfly, they call it. You're going to see ulcers in the mouth. And then the big thing is this photosensitivity. And it is a immune problem that's going on. So what is our treatment? Well, some things that can cause them flares is actually just sunlight. And you know, children like to get up and get out and go. So that sunlight can cause a flare. How do we help these children, you know, with this lupus? Well, sunscreen and limiting the amount of sun. And that will help them not to go into these flares and these pains that it can occur. If they're going for procedures, either dental or anything, they do get prophylactic antibiotics and steroids. These children should have something that identifies them. Now, JIA, also known as juvenile rheumatoid arthritis in the past, is the body's immune system attacking its joints. And what do you see? Well, you'll see those joints inflamed, but it's mostly in the morning or when you've sat down a long time, try to get up, you're stiff. And, you know, it hurts to move and it feels, you know, full and swollen. Guillain-Barré. Guillain-Barré is a condition where you've had some sort of upper respiratory a couple weeks ago, and all of a sudden you start feeling this ascending weakness, which means you'll see, number one, you'll get muscle weakness in the lower legs, you'll start waddling, then you'll start with maybe being incontinent or constipated, and then it goes up and then it hits the phrenic nerve, because it's all about the nerves in this Guillain-Barré. So how do we treat Guillain-Barré? Well, we're going to be given intravenous immunoglobulins, and we are going to support their respiratory function. So priority is monitoring respiratory function. I mean, we can treat, you know, the shuffling gait and the weakness in the lower extremities by, you know, putting them in a wheelchair. The urine problems, you know, we can do other things, but when it hits the phrenic nerve, we need to be there and prepared to monitor their respiratory function, you know, and probably it's going to be intubation, and it could go on 2 months, 4 months, 2 weeks, 4 weeks. We don't know. They're all different. And you're going to have 5 basic dosage calculations, very similar to what you've seen. You know, I believe in all of you. You guys have been great, all of the classes, and just continue doing what you're doing. Thank you guys for coming. And you all, I wish you all the best.
Thank you.
Thank
You're
you.
very welcome.